Good morning, everyone. I always enjoy that little bit of beat in the morning. I have 3 options for music on this version of Restream, you guys. Down tempo, chill hop, and lo-fi. Good thing all are beats that I like, but that's it. So you're getting some version of that every week. You're welcome. And hello, good morning. This is the Healing Hour. I am your host, Sarah Fargo O'Brien. Thank you for joining me for another episode of this podcast. This podcast is called the Healing Hour because I bring topics for healing of all kind. I work with people. For those who've never watched my show before, I'm a psychotherapist and do lots of other work with people. And between that and my writing and my research and my trauma-informed design and leadership strategy, there is just not enough information out there for folks. And I figure I might as well share what I know and then bring on some other cool people that know even more than me in their specialties and talk about some cool stuff that hopefully is going to be beneficial to folks out there listening or watching the replay. So today I have another exciting guest for you guys. Dr. Michael Louwers, I think I'm saying that correctly, is going to be on and talking to us about some cool neuroscience stuff. You guys know I have like a whole series of neuroscience episodes, the neuroscience of anxiety, the neuroscience of addiction, the neuroscience of trauma. And I think it's one of the best ways that we can understand mental health disorders, and mental health treatment, basically, and how we improve those things for folks. So I'm really excited with what we're going to be talking about today. I know I'm going to learn something. So if I'm going to learn something, you're definitely going to learn something. So thank you for being here. If you're here, let me know that you're here. Drop it in the chat. Let me do a quick little check-in. As always, my little fur children are up here today. The big brown one is directly behind my chair as usual. She grumbles and snores a little bit. So hopefully that's all we're going to get. My dogs aren't going to see any cars or people or squirrels out the window where then they just start going berserk. But if they do, I apologize in advance. My fur children like to hang out with me during the day. Hello, LinkedIn user. I'm not sure who you are. I don't know why it doesn't have your name, but it's great to see you too. I'm so glad that you are here tuning in with us. We are just getting to the check-in, just talking about my fur babies as usual. One day I might show them to you guys. I don't know. They're a little bit not easy to manage. So if they're like asleep up here and not making noise, I don't like to disturb them. And it's funny because they're up here with me often when I'm on my video sessions, and they're good about it. They know mom's talking on something and I am not to bother her. But I'm sure if you have little ones that aren't little fur children, they might not be doing the same thing. Okay, I'm rambling now. So let me check in, do my deep breaths. I'm sort of having a normal morning, had my normal things going on. It's not quite as chilly, thank God. Got to walk my dog and sort of a little bit take my time. So I think I'm in like a good space today. I haven't been running all over the place. So I'm fairly grounded already, but I'm going to take my 3 deep breaths. Gary Allen, thank you. Oh, I'm so glad you're here, Gary. Thank you for popping in and letting me know that. I don't know why it doesn't have your name up there. I'm so glad you're here. Today will be interesting. If you can stay and catch the whole thing, I encourage you to, Gary. But if not, catch the replay. Okay, you guys know I start by taking 3 deep breaths to get myself sort of centered and grounded. There is like a whole bunch of neuroscience behind deep breathing. Watch one of my other things, read some of my posts. It's all I talk about, basically. Deep breathing is my favorite intervention, coping, pause method, grounding, whatever you need. Deep breathing really kind of does it all. So 3 deep breaths as we get started. In through your nose, out through your mouth. Here we go. Inhale, number 1. Exhale, number 1. Inhale, number 2. Exhale, number 2. And number 3, inhale. Exhale, number 3. Okay. All right, I'm bringing on my guest. Do your applause. I will do my round of applause because I'm not so fancy that I have some sort of sound effect. But everyone, we are bringing on the very awesome and the very well-informed Dr. Michael. Wait. Click.
Thank you so much, Sarah. That was lovely, lovely introduction.
I'm so glad that you are here, Michael.
I
Thank you for
sincerely
spending
appreciate
time
it.
with me this
And you
morning.
did say it correct. It's Louwers.
Flowers.
That's correct. You
Good.
nailed it. Like flowers without the F. You got it.
Okay. I like
And
I like it even better now. I won't forget.
I
Yeah,
have to say a couple things before we get started. So number one, this was actually perfect timing because I was at a fundraising event this weekend and it was really loud and I completely lost my voice. I thought for sure we were going to have to cancel. And just like yesterday, my voice came back. I'm still a touch hoarse, but that was perfect timing.
I'm hoarse all the time. I sound
Well,
like
yeah,
an
when you're doing
80-year-old
this
trucker
for an
that's been
hour a
smoking
week,
cigars,
I
right?
get that.
And so that's okay, right? Horse is fine.
And the other thing I have to say is I absolutely love your deep breathing that you do at the beginning of your show. It's something that, number one, I tell my patients all the time, particularly when we're doing procedures. That's an anxiety-provoking time.
Yes.
So smell the flowers and blow out the candles is something I am constantly saying.
That's perfect.
And I think as providers, we don't do that for ourselves enough, right?
Oh, for sure.
So
for sure.
Yeah, no, I love that you're practicing what you preach there. That's wonderful.
I do my best. And I tell my clients the same thing. Like, I wouldn't offer something to them, an intervention, a coping, and anything if I wasn't willing to try it myself.
Yeah.
Vet it out. So I try to live by that, like I try to be a real person in my therapist role. And so that, I'm just here like the rest of them trying to make it and figure it out. And you offer something that I wouldn't potentially try myself to see if it would work. So that usually helps.
That's great. I love that.
Well, tell us, Michael, who you are, where you are in the world, and what kind of work you do.
Sure. So I am just outside of Cleveland, Ohio. I'm in Strongsville.
Okay. Yay. I love Cleveland. I went there for the first time last year to meet a good colleague of mine. Her name is Katie. I work with her in another organization. And it was my first time to Cleveland. And let me just say, I mean, I loved Cleveland so much. People were like, "You weirdo, why?" And it reminds me of Richmond, Virginia, which is where I'm from. It's where I'm at now. It's Center City. It's so beautiful there. It's on the water. I loved Cleveland. It was
So I'm originally I'm from Detroit area, Michigan, but I'm a Midwesterner, born and raised.
All right.
And my wife brought us down here about 15 years ago, and she was doing some training at the Cleveland Clinic.
Nice.
And she said, Mike, we're going to go down there for a year for this fellowship training. I promise that's all we'll be there, just a year. You don't, and I'm like, Cleveland, what? And we absolutely fell in love. We love the people. We love, like you're saying, that it's beautiful here. We're on the lake.
Yes.
It's just, it's a foodie town, which we love. And
that reminds me of Richmond. Richmond is a foodie town.
Yep.
And we have the river, we don't have the lake, but it's similar. Like, and it looks, our downtown, downtown that butts up against the lake is like similar to our downtown that butts up against the river. It reminds me so much of home. I enjoyed my time there. So
yeah.
I went to Detroit for the first time this year. So I went to Detroit this year for the first time and spent time in Dearborn. To visit another colleague who lives there. Enjoyed my time there as well.
Yeah, my wife grew up in Livonia, which is right next door to Dearborn. So
All
it's
right.
definitely an underrated town also.
Agreed. Agreed. Yep. Found some good stuff there. Really enjoyed it.
So, so to answer your question,
You're
so,
in
so,
Cleveland.
yeah, right. So I'm the medical director and owner of Reset Medical and Wellness Center. We treat anxiety disorders and trauma disorders. We have some unique treatments that we do. I'm not a therapist, nor am I a psychiatrist by trade, but we treat mental health. And we'll obviously get into, the specifics of what I do. But to give you a little background, so my training, I did not necessarily think this is where I would have been. I
Right.
didn't predict that. I started in physical medicine and rehab. I'm board certified in that, as well
Okay.
as anesthesia and interventional pain management.
All right.
When we moved
Yeah.
down
Okay.
to Ohio in 2012, 2011, somewhere in there, it was very much the peak of the opioid epidemic.
Yep.
And I have some training in addiction medicine. So I started my career here in Ohio doing addiction medicine,
Okay.
moving into chronic pain management.
Yep.
And the difficulty that I struggled with those patients was that while I could certainly help to some degree, there was a lot of relapse. There was a lot more to unravel than I could with the tools I had.
Mhm.
And often at the source of both of those conditions, whether it's addiction or chronic pain, is trauma, is some type of,
100%.
yes,
Yes.
emotional, physical trauma of some
Yes.
sort. And I think
So glad you said
statistically,
it. Like, I think that
yeah,
too, especially as I work in addiction. Addiction has such a stigma. My spouse is an opiate addict. He's been to rehab 3 times.
yeah,
He had to go back. He was on like a 3-year slow burn right at the beginning of our marriage. We had only been married a year, and he had to go back
yeah.
to rehab. He's about 8 years clean now again, but
Awesome. Congrats.
I totally get it. And I've worked in addiction a long time, and there's nobody I've ever seen or known with addiction who doesn't have trauma.
Yeah, I think
It just
statistically it's like 80% of
Oh, I
people
believe it.
have post-traumatic stress and anxiety disorders, but
Believe it.
I guarantee you it's just underdiagnosed,
Yep.
that they all have some type of trauma, or like I said, emotional trauma,
Yeah.
like you're well aware of, whether that's neglect or bullying or abuse or something else that
Because the drug addiction comes from somewhere.
it comes from somewhere. And obviously we see with opioid addiction, we see a lot of physical trauma too, right? They have a physical injury
Injury. Yes.
and
Yes.
that is traumatizing to deal with chronic pain,
Yes.
to
Yes, it
live with
is.
that day in and day out, to lose sleep. And then, it's kind of a natural segue to then develop addiction to the one thing that seems to be helping.
Exactly. Right?
So it was a constant struggle. And so myself and my business partner, Kelly Price, who I have to mention and thank because she's an amazing person, had set up this center with the idea to treat the real root cause of these types of patients, as well as other folks that are going through post-traumatic stress. And so the background on that is that Kelly's son is a firefighter,
Okay.
and he had pretty significant post-traumatic stress.
Mhm.
She had heard about this procedure that we do now through some friends, went to Chicago to a center there that was doing it, and had this treatment done for her son. He had amazing results. I mean, just life-changing,
For his
transformative results
PTSD.
for his post-traumatic stress. Yeah.
Mhm.
And so she was so taken aback by this that she said, listen, this is something that we have to bring to, her
Others.
hometown.
Yeah. Right.
And her background is in business, and she had sold her businesses years ago, but set up some foundations that help raise money for catastrophic need.
Okay.
Changing Lives Foundation is the name of her nonprofit that she now runs,
Okay.
and she has kind of dedicated her life now with the funds that she had from her business ventures to really helping others.
That's awesome.
Now,
Yeah,
yeah,
love that.
she's an amazing person, and she didn't have any medical training, but she wanted to set this center up to fund it to get started,
Nice.
so that other folks with post-traumatic stress could find the help they need.
That's fantastic.
And so we set it up in early 2024, and we've been going, 19 months now, 18 months now, and we're going strong.
Okay.
But we're trying to get the word out of the types of treatments that we do,
Yes.
and how it can really impact others. So that's kind of, what brought us to this.
Okay, great. So tell us what you are doing there.
Yeah. So we do a number of treatments for anxiety. We do a number of treatments for depression and post-traumatic stress. We do, for instance, ketamine, IV ketamine, which you probably are familiar with. It's an excellent option for treatment-resistant depression. We do some other treatments that help some of the physical manifestations of anxiety. As you know, folks with anxiety have tension, they have migraine headaches, they have TMJ pain, right? All these things are physical manifestations of stress and anxiety, how we carry our stress. So we do treatments for that. But really, our core treatment is a type of sympathetic block that helps to restore function in someone that has had trauma that now has this stuck fight or flight response. And it really is an amazing treatment. And I'd love to explain. I will explain it.
Yes.
I think in order for your listeners to understand it, I think we do have to take a little step back,
Yeah.
and talk a little bit more about trauma, which I
Yeah.
know you won't object to.
No, absolutely not. Right. And I'm sure they'll appreciate somebody else's perspective other than
Yeah,
mine
no,
on
well, and I
trauma.
would encourage others to listen to your podcasts on trauma. I think you had a series of 2 or 3 of them earlier this year, and they really are, they're spot on and wonderful.
I did
And
a lot of research for those. I took a
Did
deep
you?
dive into
Yeah,
neuroscience stuff.
they were brilliant. I
It's
loved
a
them.
lot in the brain, and then trying to bring it so that, I mean, I'm not a neuroscientist, but I maybe know more than the average person just from all the research. So really trying to bring it to the average person of understanding like what's happening in the brain.
Yeah.
And then what do we see then in behavior because of what's happening up here in the brain?
That's it. And I think part of the importance of telling that is understanding for patients that trauma is an injury, right?
Yes.
This is something that is a physiologic change in your anatomy and how your nervous system is responding. That's not something that you can necessarily control, right? You can't necessarily prevent that change. The way I frame it, and again, I'm going to summarize, I think, your 3 hours of podcasts in about 2 minutes. The way I frame it is that humans are very good at adapting to their environment. That's where this comes from, right? From an evolutionary perspective, humans, as they expanded out to different geographies, to different social networks, had to be able to adapt to these new environments, right? So if you move to the desert, you get used to the heat. If you move to Denver, you get used to high altitude.
If you move to the south, you get used to humidity.
Exactly.
Yeah.
And what does it really mean to say that we get used to it, right? It means that there is a change in how our nervous system is taking information from our environment, external and internal, right? That's the socialization part, meeting others' level of intensity, right? Or complementing others' level of intensity. So that's the information we're taking in from our environment. And our nervous system predicts that there will be more of the same to come, right? That's how we can adapt easily, because our nervous system says, okay, here's high altitude. Let's get used to low oxygen.
Right.
And great. Then tomorrow and the next day and the next week and the next year, we're going to survive, right?
Yes,
Survival response.
Yes.
And what a lot of people don't recognize, what a lot of people don't know is that response is constantly going off, right? There's a balance. There's a balance between your fight or flight response and your rest and digest response, your
Yes.
sympathetic and parasympathetic response, right? Polyvagal theory, Stephen Porges had it right. So as that is going on, it's constant. It's about 100 times a day that's occurring.
Wow.
And that balance is what's important, right? It goes back and forth. But as we get used to a situation, the challenges, most of that time it's helpful, right? It's adaptive. It's good.
That's right. It's purposeful for
It's
where we
purposeful.
have come evolutionary
It helps
wise,
us.
right? Exactly. We wouldn't be here if we weren't able to adapt to these things.
The difficulty, of course, is if your environment is intense, if your environment is stressful, if your environment, of course, is traumatizing, your nervous system recognizes that, expects more of the same, and changes the level of response that our nervous system then gives to its environment, essentially getting our fight or flight system more and more activation. Right?
Yes.
And then even, this is really where it's critical, even when you're taking out of that environment, you're put in a safe environment, and you have a support network, and you have, the treatment that you need, your nervous system doesn't care.
Yeah, right.
Your nervous system says
it's trained for this over
it's
here.
trained for that.
Yeah.
Right. And so it's going to respond then to cues in our environment that aren't even threatening anymore, right? Because your threat response meter is sitting at a 9 all the time now. It's essentially stuck in that fight or flight state. And so you'll develop these cues. We call them triggers. Of course, they're, neuroactivation, more appropriate term, but nonetheless, these cues are then setting off that same system to the point where in some folks, it's just going off constantly.
That's right.
And the difficulty in treating that, as you as a therapist are well aware, is that for this evolutionary system to work, there is a certain sequence that it has to go in, right?
Yeah.
Your sympathetic system, your fight or flight system, your survival response has to come first before your behavior, right? If there actually is a life-threatening event, if there's a bear charging you,
that's right. You don't want to have to stop and think about it.
You don't want to stop thinking about it. Your brain sends a signal to your adrenal gland.
Yeah,
and
the amygdala works faster than the prefrontal cortex, right? Like
the amygdala works so fast that if there actually was a bear charging you, your body has already reacted before you even recognize that it's a bear.
That's right.
Right?
It's amazing, right? That's an amazing survival skill, but not great if there's no bear.
Not great if there's no bear. And so what does it feel like? What would it feel like? This is to put yourself in your patient's, seat. What would it feel like if there was a bear charging you? I mean, it would feel intense and awful, and you can't concentrate, and your heart's racing, and you're having a panic, right? Yes. Again, in that situation, it's helpful. But if that's going on all the time, there's no bear, then of course we get hypervigilance and restlessness and insomnia. We get irritability and short fuse. We get panic attacks. We get brain fog because we can't concentrate, right? And so that's, of course, the definition of anxiety and post-traumatic stress.
Yep.
So the difficulty there is that when the system is constantly going off, and then you do something very appropriate, like say, take a deep breath, right? Like we've done, like we talked about, like I tell my patients all the time, or other mindfulness techniques, or you're in counseling, right? The challenge there is what you're trying to do is change a behavior or a coping mechanism after that threat response is already elevated. Now, it's very doable, and for many, it can work, and you can bring that threat down, but you're constantly dialing down against this elevated reactivity.
Right, like it wants to go up here, you have tools to bring it down, but it's constantly.
But it's a constant struggle. It's a constant fight. And again, for some, they can do it. For others, you end up after a year of therapy and they still can't even discuss what their trigger is, right?
Yeah.
And that's very frustrating for the patient and for the provider. And so what our treatment does is it is a root cause treatment. Our treatment targets that injury, right? That change in the nervous system, that hyperactivation, and reduces it back to its baseline, restores the normal function of your sympathetic and parasympathetic tone, not get rid of it. Again, you don't want to get rid of that fight or flight response. It's critical. Like we said, it goes off 100 times a day. That's a good thing, but it's balanced. It's balanced by that parasympathetic. And when you don't have that, you lose that control, right?
Yeah.
So how we do this is very simple. We do a nerve block to the sympathetic nervous system. The control center for our sympathetic nervous system is located here in our neck. And it goes by a few different names, but you'll hear the term stellate ganglion or sympathetic chain or cervical sympathetic chain. It's just a collection of nerves, okay, along a segue between that amygdala and limbic system and survival processing and emotional response system and your body's response, your physical response, right? And if I block it, if I numb it temporarily for a few hours, that allows that system to start to function normally again, right? It's like what's the first thing you do if your computer's frozen? All the apps aren't working, right? You do a hard reset, right?
You turn it off, back on.
And you turn it back on. Okay. Well, surprisingly, our body works very similarly. Okay. If a nerve is constantly in an activated state, you can change it back to its normal state by simply turning it off for a short while. Now, what's actually going on anatomically, for your information, is it's downregulating the connections to that limbic system, the overactivation and lowering things like nerve growth factor and norepinephrine, which has promoted all this sprouting of the sympathetic system into the limbic system and amygdala. So, so it's like trimming those branches, right? Okay. Those excessive branches.
Okay.
Now, again, when the numbness wears off, the system is still working, but it's not stuck on. And that gives the patient back that control. So then when they take a deep breath, when they do counseling, they've made space for that.
Yeah.
Right. Now it actually.
Then there's less effort to bring down the reactivity.
That's it. Because you're starting at a 1 or a 2 instead of starting at a 9.
Yeah. Okay.
And what's particularly cool about this, because I know the first question is, well, how long does that help for? Right.
Sure. Yeah.
Yeah. So what's particularly neat is that in the vast majority of patients, and we're seeing this from the studies that we're doing, from our data, and from research from some of my colleagues around the country, is that even done a single time, this can potentially have years of benefit.
Wow.
Yeah, this isn't like a cortisone shot in your knee for arthritis, that you need every 3 months until you finally get the knee replacement. This is really a significant and clinically meaningful treatment for post-traumatic stress. If we can lower that response, then what happens? Then they're able to make that progress that they hadn't been able to make for all those years being stuck, right? Now they can move forward. And in patients that integrate therapy and mindfulness practice after this, they
slam dunk.
They can maintain it, right? It's like any other injury, right? If you broke your leg, you can walk on it. It'll hurt like hell, and you're not going to walk right, but you can walk on it.
You're not going to function well.
But you're not going to function
like it's supposed to. Yes.
If we can simply provide the way for this system to heal, to really heal itself, but give it that boost to heal, cast it, right?
Yeah.
Fix it.
Yeah.
Then you can rehabilitate it. Then you can start strengthening. Then you can start healing from this injury. And that's what this treatment does. And that's why it's so amazing and so successful.
Yeah, it is amazing.
It is amazing. Now, here's the crazy part. Not a lot of people know about it. And it's been around for about 30 years, which blows people's minds also.
What
Yeah,
is it?
people think I
It's
invented it. Not the case.
you're like
Um,
you're like, "Not the case.
yeah.
I wouldn't just
So,
have this medical center in Cleveland."
yeah,
Right? And be
sorry,
like,
I
"You
can't
wouldn't
take
be on
credit
my podcast
for
at
that.
all."
Yeah. So,
So
so
is it the ketamine is this the ketamine stuff?
no, 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 no.
Okay.
So the block itself is done with an anesthetic called ropivacaine. It's just an anesthetic. We use it for regional blocks in anesthesia all the time. It's a very common anesthetic. And the actual type of nerve block that we're doing is also super common. It's done in pain management for certain types of very rare nerve injuries.
Mm,
One of the more common nerve injuries that it's used to treat is phantom limb pain in like amputees. You may have heard of that. That's where you
okay.
lose a limb, but you can
Yeah.
still feel
Still
the
feel it.
limb or feel pain from it.
Yeah.
Well, guess what? In the 90s, they were doing this treatment for that type of individual in the veteran system, a lot of
Right.
amputees, and of course, what? A lot of post traumatic stress.
Oh, yeah. Yeah.
And what they were finding is these folks were coming back and saying, yeah, my phantom limb pain is better, but I'm not waking up with nightmares all the time. Why is that?
Right.
And so a couple of my colleagues around the world started studying this a lot in the veteran system.
Mhm.
Dr. Lipov out of Chicago and Dr. Sean Mulvaney out of Annapolis. He's a former Navy SEAL
Yep.
and a physician. And the two of them have done a lot of the background research on this over the last 25 years now. And it's expanded from there. But unfortunately, the VA system, while some veteran hospitals will do this, there's a lot of red tape to it.
So much red tape.
And active military don't
Yeah.
often want to do this because they'll get kicked off their team. There's a stigma, et cetera. So they're often reluctant for that. So it's hard to go through the veteran system, and insurance won't cover it yet for mental health, and so it's self-pay. Now, what we do here is we work, especially with first responders and military, we work with a number of different nonprofits, foundations that offer grants to support these individuals through their trauma.
Nice.
And we end up about 30 to 40% of my clientele is military and first responders
Okay.
for that reason, because
Yeah.
there are these foundations that help
Support
them
them coming
help,
into your
help.
clinic to get the care that
Ex-
they need. Yeah.
Exactly.
That's awesome.
Yeah, and that includes about a third of my patients that are special operators. So spec ops like Navy SEALs, Green Beret, Rangers, all those individuals come through my office because again, they
They
don't
got
want
so
to go.
much stuff
They
and
have so
they're
much
not
stuff.
talking to anybody about it.
Yeah,
Yeah.
and it's
Ever.
I will tell you, it's very rewarding though.
Yeah, I
Treat
bet.
these individuals, and again, obviously that community is where historically we think of post traumatic stress, but keep in mind the other 60% of the folks I treat are like you and me and every other person, right? Their trauma is from maybe bullying or emotional neglect, or maybe it's socioeconomic or going through a divorce or those types of things. And that can be just as hard on the nervous system, just as stressful, just as traumatizing as anything else.
Yeah, so does this work with things like CPTSD? Complex?
Yes, absolutely. In fact, I would say the most common patient I treat is someone with complex trauma, right? Because they sometimes use the analogy of these different buckets that they're carrying or backpacks that they hold, right? They have their trauma from the childhood. They have trauma from maybe they were a first responder or a military, and then they have their trauma from the current relationships or whatnot that they're
Yep.
struggling with, right?
Yep.
And those are the folks that are usually hyper activated, right? Their fight or flight system is really just stuck at a 10 all the time because of all this trauma that they carry.
Right.
And
It's how they
so
survived.
that's how
But
they survive.
basically, the nervous system survival responses, instincts, and cues will kill you if you're not actually in I need to survive situation like the
Yep.
bear,
Yeah.
right? Because it's too much on the, we can't live at a 10.
It's too much.
It's too much for like the body.
Well, and we haven't even gotten into this, but I mean, yeah, those folks that are living at 10, I mean, it's like, think of it this way. In those Fast and the Furious movies,
Yeah.
right? Where they always have that like little red or yellow
Yeah.
button,
And
right?
you get
And
like
you like push
super
it.
red. Yeah.
Yeah. And you get that like nitrous into my son loves these movies. So
Yeah.
that's why I say. But those are intended to be like short bursts of energy,
That's
right? That's what adrenaline is. That's what cortisol is. It's
yes.
meant to be this short,
Burst.
boost,
Yeah.
yeah, to get you through this life-threatening event. When that system is stuck on, when your cortisol levels are constantly elevated, that is very damaging. It causes chronic inflammation, neuroinflammatory diseases, which is one of my areas of research, things like migraine headaches, inflammatory bowel disease, fibromyalgia. It contributes to weight fluctuations,
Yes.
GI issues. I mean, the list goes on and on.
Insomnia,
And so there are physical
metabolic problems.
ramifications. Yeah, which is again why we here do treat some of those conditions, but those are usually secondary
Yes.
conditions, but you really have to treat the underlying issue first.
Yes. Otherwise, let's tell you what happens, guys. Basically, I'm the poster child for this and treat a bunch of people the poster child for this. But if you don't treat the underlying issue, kind of like with addiction, the symptoms just keep coming back and you just keep having to go to the doctor for your high inflammation, for your insomnia, for your GI issues, for your chronic pain, for like those are not going to go away. We're just going to keep treating those to some degree unless we get to the root cause, exactly like
Yeah.
you're saying, the thing that's driving
Yeah.
all of those symptoms, all of those health disorders and issues.
And one of my pet peeves is of course sick care in the United States, right? That's what it really is. It's
Yes,
it's a
sir.
system that through no fault of the providers necessarily
Right.
is designed to fail, right? Because your provider is now spending, and this was me before I started the center, spending an hour on the phone with the insurance company, doing prior authorizations, getting this approved, getting that approved,
Stupid.
and documenting, and God forbid you put in the wrong ICD-10 code, and
Jesus, right.
they don't get this approved, and then you add an ICD-10 code, and now the patient's carrying the stigma of some disease that you had to diagnose because that's the only way they could get their MRI approved,
Yep.
right?
Yes.
And we know what happens there. So it's a horrible system. You end up spending 10 minutes with the patient. It's a volume-based system, and it just perpetuates I went to the cardiologist because my chest hurt. He cleared me, but he was like, I have no idea what's going on. I went to the GI doctor because, I have this bowel issue.
Yes.
He did the scope. Everything looked good. He doesn't know what's going on.
Exactly. Then nobody
right?
helps you.
No
And
one
then you
helps
go
you
in
because
someplace
no
else
one
and they're
has
like,
the
you're
bigger
crazy. There's
picture in
nothing
mind.
wrong. And it's like, there's something wrong, man. There's something wrong. Right.
Yeah.
And they're just like, we
Yes.
can't find it. We don't see it. Right. Yeah.
And I practice value-based care. I want to sit with my patient and I want to listen to them.
That's awesome.
In my pain practice, which I did not own prior to coming here, I might see 40 patients in a day.
Oh my
And
God, man.
I would try to give them the best value that I could, but you just can't.
You can't in a system like
You
that.
can't do that in a system like this. And that's why, and at the end of the day, again, I'm not really treating a lot of the root cause.
No. We're symptom management.
We're symptom management.
We're
Now,
symptom managing.
on a busy day, I'll see 10 patients. I sit with my patients for an hour.
Yeah.
I talk them through this. I talk them through the resources that they're going to need after this. I want to make sure that they have the connections, that they're doing the right things after, not just, hey, here's your shot. Good luck to you. Because if you think about it that way, like we talked about earlier, it's not going to be effective for very long.
No.
Eventually that system will reactivate and you'll be at the same point you were.
Because you have to make changes that behaviorally to kind of hold your system where it's
right?
at.
I can change your
doing the same
physiology.
things and expecting your nervous system not to then react in the same way. Right. Yeah. We're just going to repeat the cycle and then
You're just going to repeat the cycle, right? You'll be back in, 3 months. yes, it has to be a lifestyle change, and it has to be looking at the root cause as well as preventative medicine, right? And if we can do that, I think we have a much better system at play. I don't remember what the original question is. Probably got off track,
It's
but
fine.
yeah, but I think that's what really has to happen, and that's what we do at our center.
What's the preventative medicine then post that? Like what?
Yeah. So what we do is essentially we have a number of resources that we have contacted with over the last 2 years. I have made it my mission to touch base with every nonprofit foundation in the country that works to do post-traumatic stress treatment, that works with anxiety disorders, that works with military first responders, civilians, anyone that needs treatment. I have made it my mission to touch base with as many mental health providers as I can. Like I said, I'm not a therapist, right? But I want to make sure you have that resource.
Mhm. Yeah.
So we give in addition to just, general information like how to do deep breathing,
Yes.
we give the patient the resources that they need afterwards
Okay.
to get the most out of this, right? To be able to maintain that. That's the preventative thing. And often, again, it's things they can do on their own,
Yeah.
teaching them mindfulness and telling
Right.
them where the yoga studio is, and go with your wife so she can be an accountability partner, right? That's where the
Yeah.
prevention is. It's looking at this from a holistic approach, from a
Yes.
mind and body approach. I work with a lot of functional medicine providers for the same
Yes.
reason,
Right.
right? Because our mind is directly connected to our gut. And the person that was having panic attacks and chest pain is getting better from that. The person who's having gut issues and absorption issues, he's going to the functional medicine doctor. He's getting better from that. So it is about this continuum of maintenance, and not here's another, and I'm not against medication, but here's another pill for your, hypertension,
Sure.
and here's another anxiety pill, and here's some Xanax for you. That's not solving anything.
Hell no, it's not. Nope. Sure
Yeah.
isn't. And that's what also people don't understand about like therapy and counseling. It's like it's preventative from people ending up in like a crisis situation.
Yeah.
Even if it seems like they're super functional. Like I was just talking about this with someone yesterday, our client, like I have like the same 5 or 6 clients like every Wednesday. Everybody has like a slot, right?
Yeah.
And but you never know what to expect. I can't know what to expect in this job. I've been working with some of these people 8, 9 years and every week, right? And it's like, but I don't know what's going to happen in their life. And sometimes they get on and it's like everything's imploded. I don't, like their dog died. They found out their wife was cheating on them, like, and it's like, all right, well, now we got work to do. And if they weren't already set up in therapy, those type of stressors will just make somebody if they don't have good strategies, they're not going to use good strategies.
Right. Stress is a simple equation. This is the best way I can explain it to your listeners, to my patients. Stress is a simple equation. It's just like finances, right? Finances, you have money in and you have expenditures, right? Yeah. Money and expenditure. I was never a business owner prior to this, so I'm just kind of learning that kind of stuff. But that's what stress is, right? You have stressors around you, and then how we take them in and how we respond to them really defines our mental health. Now, stressors, you might think you can change, right? And you can certainly set boundaries, right? And you can certainly
you can do your best to minimize
prioritize, right? The important things, and prioritize self-care, right? Absolutely. Self-care is not selfish. I'm sure you've said that on one of your podcasts.
I'm sure I have. A million times probably.
So, you can do that. But at the end of the day, like you're saying, guess what? In 2 weeks, in a year, some other stressor is going to pop up. Yep. And how are you going to deal with that? It's about how our physiology is managing that stress, right? How our body is reflexively responding to it. And then the behavior that we enable, right? Is it healthy? Is it good coping strategies? Right. Or are you having 2 glasses of wine every night because that's the only way you can fall asleep? Right. And not against alcohol, but it's not everything in moderation. It's everything in moderation for the right reason.
Yeah.
Right.
Yeah.
That's what's
right.
Really
if we're using it to like treat something, address something.
Right. If we're using
Right.
it to treat our anxiety, that's not helpful. If we're having a glass of wine because, we enjoy wine with dinner, that's fine. Great. Everything in moderation.
Right.
But how we're coping with stress is critical. And if we don't teach that, and if patients don't understand that, like you said, we'll see you in 6 months.
Right. And I find the same with psychiatric medication. I'm not against psychiatric medication. I'm on my own psychiatric medication. I've been in and out of that over the years. It was about 2 years ago, I did psychological testing myself as I was experiencing more and more brain fog and lack of focus, and was like, maybe I have ADHD that was
Yeah.
never addressed. No, well, number one, I have a shit ton of trauma. Everybody knows that watches anything that I do. So I actually might be coming to your facility since
Fair.
this is the best thing that I've heard.
Fair.
Right. Um, and then the other thing is you shouldn't be taking psychiatric medication by itself. Like, you should be in therapy at the same time.
Correct. Yeah.
So this is a conversation. And also, I'm not a huge fan, just going to say it. I know people do it and I know why you do it. And it's because the system sucks and insurance is shitty and all of it. But like, your primary care doctor should not be prescribing medication for your mental health. You need to see a mental health provider. You need to see a specialist who understands mental health, and what I find is like, they know how to use things off label that is often not used by primary care. They try to keep it to the minimal amount of medication and dose that you possibly could need without overprescribing. And they also are much better when you need an adjustment. Like, if you need any of your medications adjusted, your primary care is just not going to do well. They're going to go up on what you're on. And then if it doesn't work, just like put you on something else similar, different. And so
there's specialists for a reason.
Exactly. And I educate my clients on this. I don't obviously do not force anybody to take medication, but if they're interested, it's like, all right, well, let's have some conversations.
Right person.
Yeah, let's have some conversations about what I know. Even though I'm not a medical provider and I'm not an NP and I'm not an MD, which is, I always let them know I can't give you medical advice, but I can give you perspective and then encourage you to go talk to a medical professional and a specialist. And I do my best to I try to keep, those good ones in my pocket and refer them out to my folks.
Yeah.
And
that's
because I let them know you're not going to get as good of care for your mental health from your primary care doctor. You're just not. Like, if there's actually an issue there that needs treatment and that you're taking medication for. And again,
everything is stable. That's one thing. But if it's not stable, I think I agree. I mean, seeing a specialist is important. And like you said, underlying, the preventative and maintenance is really what's important. So take that blood pressure medication, but also you got to cut back salt and you have to exercise and you have to get good sleep, right?
Right. And it's the same. Take that psychiatric medication and go to therapy and practice deep breathing and do self-care and get into mindfulness. You can't just take the medicine and think it's going to solve everything.
And patients ask me that all the time, can I do this treatment to get off my medication? Well, sometimes yes. But it really depends. And to be fair, this is not a panacea. It's not a perfect treatment. It's not going to work for every person. But the good news is our data and the current literature and randomized controlled trials that are out there now are showing that about 75% of patients are clinical responders to this treatment, meaning from a psychiatric perspective, their drop in their PCL5 is 10 points or more and maintained beyond 6 months, which is really for people listening that don't know what that is, it's an objective scale of our post-traumatic stress symptoms. And it's a standardized and validated tool to measure post-traumatic stress. And to have a drop of 10 points is clinically very significant. And so these patients are having objective and of course subjective measures of improvement that's being maintained. And again, that is really critical. That one of the big studies that we're starting now, along with one of the foundations that we work with, is looking at the types of then integrated treatment that are really important afterwards.
Yeah. Right. And I'm really curious about that treatment, right? Like, what kind of results do you see post 6 months when they engage in some of these other things, like after the treatment with you, right?
Right.
So
and the answer, of course, is obvious, but the more they
Then you got
do,
to prove it. Okay, you got to put in the research.
the better they do.
Yeah.
But you still need to, publish that type of data.
Exactly.
That's what's
Exactly. So that people know that.
Yeah. And then what we're also looking at, and I think before we got on, you had referenced a study I just published last month.
Yeah.
But we're also looking at some of the related conditions, like we mentioned earlier, some of these other conditions that are indirectly related to anxiety or contribute to anxiety or go back and forth, and how those conditions might respond
Yeah.
to this treatment. So interestingly, this treatment has also been done for long COVID, because long COVID is a chronic inflammatory disease.
Huh.
And that chronic inflammation is mediated by the sympathetic nervous system.
Right. Right.
And so the paper I published last month was on traumatic brain injury. So I had a patient that had a mild traumatic brain injury that was not traumatizing in how it occurred, right? He simply bumped his head. But he had a lot of the same symptoms as someone with post-traumatic stress. There's a lot of overlap with those two conditions, right? Anxiety, restlessness, insomnia, all come along with, of course, like headaches and visual changes that go along just with TBI. Now, he didn't have like the nightmares and the hypervigilance that someone with post-traumatic stress gets, but he had those overlapping symptoms. And what I showed is that that he had nearly complete resolution of all these symptoms now 2 years after his head injury had occurred, because he had this treatment. It reduced that sympathetic activation that's often caused by a traumatic brain injury.
Interesting.
Yeah. So there's all these other conditions that are either come from anxiety.
Yep.
Again, like neuroinflammatory conditions, fibromyalgia is worsened by anxiety. Migraine headaches are worsened by anxiety, right? Inflammatory bowel disease, psoriasis, those things are all worsened by anxiety. Yeah. And so we're seeing improvements in those conditions secondarily, but also other primary diagnoses that kind of cause or overlap with post-traumatic stress or anxiety. And again, some of my colleagues around the country, like Dr. Mulvaney in Annapolis, is showing similar things.
Okay, I have a couple of questions. One, how does this treatment relate to TMS? Are you familiar with TMS?
Yeah, very, very familiar with TMS. So, a lot of times there's no direct relationship there. A lot of times we talk about, well, in EMDR, I get that question a lot too, right? We talk about reprocessing of how our emotions and memories intertwine.
Yeah.
Right. I mean, that's really what EMDR is it's reprocessing emotions and memories in a healthy way. And TMS is doing that just with magnets, essentially. Right. And TMS can be very effective. I don't do TMS personally. I have some colleagues in the area that do. So that's another one of those things that sometimes if someone is interested in that, I will send them after this treatment to do that. Same with EMDR and other forms of trauma therapy. But it can complement this, but it definitely works in a different way.
Yeah.
Right. So
and usually, well, TMS was sort of started for treatment-resistant depression.
Yes.
And more recently, it's been approved for like treatment-resistant OCD or something.
Yeah, I would liken it closer to how ketamine works. Ketamine works by taking advantage of adaptive neuroplasticity, right? That's our brain's ability to quickly form new connections. They can be healthy connections or it can be unhealthy connections.
Yeah.
But it heals and repairs really quickly, right? That's why we see folks that have a stroke and one day can't move the right side of their body, and 2 weeks later they're rehabilitated, right? The part of the brain died. Why is that? It's because the brain is very plastic. It's very adaptive. And so TMS takes advantage of that. Ketamine takes advantage of that. It helps to promote the formation of new connections, specifically new connections that can help with emotional processing. Right. Because that's critical to dealing with trauma, to being more resilient to trauma.
Yes.
Our treatment, again, and we call it a neurosympathetic reset or a sympathetic block, but neurosympathetic reset, that's
Okay, I
kind of
like
a
that.
trademark name.
No, it's good. I get it. That makes sense now.
Um,
Like, now that you've explained all this, it's like, yeah,
yes,
okay, the
yeah,
reset makes
neurosympathetic
sense.
reset.
Yeah.
So that takes advantage of kind of that same system, our brain's ability to heal, but by directly turning off that sympathetic input
Okay.
temporarily. So they're working for the same end
Yeah.
result, right? Which is treating trauma and anxiety and
Different
depression.
mechanism.
They go about it in two different
Yeah.
ways.
Different mechanism. Okay.
Yeah, but they're very complementary to each other.
Okay.
And some of my colleagues around the country are looking at that complement specifically, like ketamine plus sympathetic treatment, or ketamine plus TMS, or sympathetic treatment plus TMS, et cetera.
Okay. Another question. Can you get this treatment and remain on your psychiatric medications and
Yeah,
or health medications?
of course.
Okay.
Yes, absolutely. I don't prescribe any medications here.
Okay.
I had, 15, 17 years of prescribing medications
For
and
40,
treating
40
addiction
sessions a
and
day.
Suboxone and
Yeah.
methadone, and
Right.
it was a lot. And
Oh, yeah.
and again, I am not against medications at all.
Exactly.
I think they
They're
have
really,
their
and
place.
especially those, and methadone and Suboxone are really helpful for a time. My spouse was on
Absolutely.
methadone for a while.
Absolutely.
Like, yeah, they're
But what I advocate for is that, I usually say don't do anything for a couple weeks after any treatment, right? That's usually a good idea. See what the effects are so you're
don't
not
change anything.
intermingling,
Yeah.
apples to
Don't change
apples
anything.
comparison. And then if things are going well, talk to your doctor
Yeah.
about what changes you may want to make. And many times it's just they're able to take a lower dose. But
Exactly.
what's the most common antidepressant, right? It's a SSRI.
Yes.
Serotonin, which is critical to raise mood, elevate endorphins, has a inverse relationship with cortisol,
Yeah.
right? So when cortisol is constantly elevated, it's
Serotonin.
expected that your serotonin is going to plummet.
Yeah.
And what we see, and another study that we're looking to get into, is measuring cortisol levels before and after treatment. We've done that for some of these patients,
Awesome.
and of course, expectedly, they've had a significant drop. And as cortisol drops, serotonin starts to raise, and guess what? 3 weeks after the treatment, your mood's better.
Right.
Yeah.
Right. And it feels miraculous.
And it feels miraculous.
But
No,
this is like the neurophysiological part,
that's the
like what we're seeing
neurophysiologic
on the
changes
outside.
as those neurochemicals create that natural balance. What's particularly cool, though, and I didn't mention this with my explanation earlier, is that when your sympathetic system is stuck on, it really is on 24/7. I mean, that's why people are getting up at 2 a.m. and they can't sleep and they're having nightmares, et cetera. It's on 24/7.
Yes.
When we do this treatment, many patients have relief before I even sit them up. That's how transformative this is, because that system is just going.
Yeah.
I numb it, I turn it off,
Right.
and they can take a deep breath.
Wow.
They can there's an emotional aspect to it, right?
Oh, yeah.
We don't recognize as much how our emotions are suppressed by trauma,
By trying
right?
to survive. Yeah.
But it makes sense, right? If you're in a survival,
State.
situation,
Yeah.
like that bear's chasing you, like we talked about earlier, you can't necessarily feel sad or, happy or
Or a little,
excited or
or
angry.
process,
You can't process it.
sadness
You're
or
not
process
intended to
anger.
process. There's essentially a switch that is clicked off,
Yeah.
right? And so the amygdala just takes over,
That's right.
and it's this survival response. Now, the difficulty is if that happens again and again and again and again and again, eventually you just stop processing those emotions and you just carry them. When we do this block, people have an emotional release because they're finally able to start processing it, which is, of course, why it's even more important that they follow up with their counselor to learn how to process those emotions in a healthy way. But that's what we're seeing, is that there's immediate laughter. There's immediate crying. There's immediate feeling high.
Wow.
And this is, again, there's an anesthetic. It's just
Right.
like the Novocaine the dentist uses. It is a
Right.
common anesthetic used for a nerve block. It's nothing special. It's just done in the right way, in the
Right.
right population.
Huh. 2 more questions
Yeah, hit me with it.
for my own interest, and then we'll wrap up. Have you found success with this with OCD?
Yeah. So what's particularly hits home with me about that is my daughter struggles with OCD.
So that's
Pretty
what I was
severe.
gonna say when I did psych testing to find out if I had ADHD. Do not have ADHD. I have OCD though.
Yes. So many folks are misdiagnosed. Again, from a non-psychiatrist perspective,
Yeah.
many folks are misdiagnosed with ADHD. They really have severe trauma and anxiety. And
Yes.
that's what's causing those wheels to spin, that hamster wheel to go
Yes.
and go and go. But OCD, while it's no longer under the umbrella technically of an anxiety disorder, now in the DSM-5 and 4, it has its own category.
Right.
But it
Very much
really,
related to anxiety
it
though. Like I get
really
it, it's
is.
its own thing, but like
It
comes
really
with a
is
lot of
the same
anxiety.
type of thing.
Yeah.
So I have a couple case studies I am doing. There is no literature that
Okay.
currently supports this for OCD.
Okay.
Obviously, ERP is the standard of care, but uh, we have seen anecdotally some benefit with OCD, again because it very much relates to anxiety, and
Yeah.
so there are some improvements, but purely anecdotal.
Okay. Well, that's interesting. Okay. Last question out of my own curiosity. Any experience either like treating patients or in your research, I guess, or like a byproduct of this, and anybody that's had shingles or no, nerve pain or damage from having shingles?
Yeah, you need that from a family member or something that has had
Me,
you.
this one,
Oh yeah,
yeah. And I
shingles.
had the nerve pain for a year, and 100% believe that, and I got it a few years ago, that the shingles was triggered by stress.
Yeah,
For
yeah.
sure.
Shingles is one of the most horrific nerve pains. Well, postherpetic neuralgia is the medical term for it. It's
Yeah,
one of
thank
the
you for
most.
saying that because it was literally the worst illness I've ever had in my life,
Yeah, no,
and has irreparably changed the way my body works now.
it is horrific. It is horrific,
Indeed.
and particularly if it's in a area that like your face,
Oh,
or
yeah,
in an area that that is touching clothing. I mean, it is it's
it was
really
bad.
bad.
It was so bad.
So yes and no to that
Okay.
answer. So obviously, that is caused by a virus,
Yep,
right? A virus that remains dormant in your nervous system that then pokes its ugly head when you're stressed.
that's right.
Like any chronic illness, it is often manifested by anxiety, right? You're stressed, and
Stress.
so your immune system weakens, and
Yep,
so these type of opportunistic viruses then take hold.
that's right.
And that's true for any illness, really. I mean, any virus or bacteria will often do that, takes advantage. That's why folks that have anxiety and stress and don't sleep tend to get more sick,
Sick.
right?
Yes.
So obviously, like we
And
talked
this is
about.
that's another way, guys, mental health relates to physical health, and that their physical health is often poorer in individuals with mental health issues because of this very reason.
Yeah.
Yes.
So obviously, circumstantial stress, like we established earlier, you can't necessarily avoid.
That's right.
But if you're in a situation where even someone like you, Sarah, who does deep breathing probably multiple times a day and definitely practices what she preaches, if your physiology is dictating
Yeah.
a unhealthy response to stress,
Mhm.
then these types of situations will be more problematic.
Yep.
That things like shingles and postherpetic neuralgia can happen. I can't treat a virus with this, right?
All right. Right.
But I can treat how your physiology responds to stress.
Yeah.
And so even when you're doing all the right things,
Right.
that doesn't necessarily mean that your body is doing all the right things.
That's right. Yeah.
And it has to be both sides of that, right? It has to be, each one is 50% of the
That's
equation.
right. Yeah.
And so, yes, I can help that by changing the way your physiology responds to stress. And then when you do all your helpful mindfulness practices, you can really, control that and are much less likely than to get another shingles outbreak next time you have,
Yeah.
an
A lot
event
of stress.
that's stressful.
Yeah, I'm really curious to see as you do this over time, because I'm sure you're familiar with autoimmune diseases and disorders linking to trauma. And
Yeah,
it's basically like your body turning on yourself because there's too much cortisol and there's too much
right,
stress and there's too much inflammation. And then
right.
you get all these autoimmune. So, um, really curious over time if you see a decrease in autoimmune as a result of addressing people's stress.
Yeah, absolutely. And we've treated some folks with autoimmune diseases, not to treat the autoimmune disease,
They just
obviously,
had one.
but to
Yeah.
treat their
Yeah.
underlying, trauma. And they have had improvement. What I would say with any autoimmune or neuroinflammatory condition is that these conditions are unlikely to resolve with treating the anxiety. But what does happen is you see an improvement in the frequency and severity,
Yeah.
right?
Yeah.
Migraine headaches probably being the most common one I see, right?
Okay.
Someone who has migraines 3 times a week
Right. Right.
goes down to having them once a month,
Exactly. Yep.
right?
Okay.
And of course, these conditions also have environmental triggers too that you just can't control, not mental health triggers, but just, the seasonal change or allergens, right? Those types of things will still contribute to these conditions.
Sure.
But if you can remove the stress and
That's right.
anxiety factor, that helps a lot.
Yeah. I could totally see that. And autoimmune is linked kind of like addiction to trauma, right? And it's
Yes.
just like we don't know another way to
I,
deal with it.
I
Our
would I
bodies
would
are
argue that every system in your body is linked to trauma and stress. Our sympathetic and parasympathetic control system, right? That part of our nervous system has connections to everything. Our temperature regulation, our immune regulation, our
saliva
cardiovascular, our
production. Yes,
GI, the
reflex.
reproductive, our musculoskeletal. Every part of your body is constantly in communication with that. And if there is dysautonomia, right? If there's dysfunction in
Yeah.
the balance that we talked about between our sympathetic and parasympathetic system, then all those subsequent systems will be affected in some way.
Yeah. Okay. We are almost done. I do have one more question.
Okay, sure. Yeah.
Just walk us through the process. Like if somebody comes to get like, what is it
Yeah.
like? They come in, they say, you give them a shot. Like, what's the process? Are they
Yeah,
there
it's
for
just as
2
easy as
hours?
that. They just come in off the street and just give them a shot. So we take pride in our patient engagement and how we process this because again, we are not volume based here. I really am value based. So if someone is interested, they go to our website, which is theresetcenter.com. And there's a free assessment that they can take there. My patient engagement team will contact them, walk them through essentially what you and I have talked about for the
Okay.
last hour. Everything from what their specific worries are, triggers are, what their mental health situation is, who they're working with, to our process, how our treatments work, etc. We're going to do an intake of assessments like we talked about earlier. We're going to do a PCL5, a GAD-7, a PHQ-9. These are objective measures to assess their mental health. And then we're going to do a medical intake also. So some basic, new patient forms that you would fill out.
Yep.
I offer free consultations. So if someone is just thinking about this, but not sure, or has specific questions, they can come in or meet me virtually and we can go over their specific condition. Like for instance, you mentioned OCD. I have a number of parents that, struggle with their kids that have OCD. By the way, on a side note, we treat 16 and up.
Okay.
And so after that process is done, they're interested in treatment. We schedule them. Usually the scheduling process is maybe a couple weeks out.
Okay.
A lot of my patients are traveling from outside of Ohio. Obviously, about 50% of my clientele come from other parts of the country or other parts of the world. So they have to arrange that. And then they're here for 2 separate days. So we have a sympathetic chain on our right side and we have a sympathetic chain on our left side. And to get the most optimal outcome, we have to treat both, but we can't do it the same day. It's too much numbing medicine.
Makes
So we do
sense.
one side one day and we do one side the other day. The actual treatment, you're probably here for about 2 hours.
Okay.
You need a driver. You can ride share, but you need someone to drive you home to your hotel or home. The actual procedure takes about 20 minutes. It's a super simple procedure. We usually just use a local anesthetic like lidocaine to numb the surface, and then do the block. You feel some pressure when we do the block. There's some regional effects that we expect to see because it's a regional block. The medicine spreads to the surrounding areas. So you get numbness kind of in your shoulder, in your neck, in your face, and your face gets a little droopy from all the numbness, and your eye gets droopy. And we actually like to see those effects because it tells us that we had an effective block.
All right.
We do that one day. We do the other side the next day. Of course, I go through with the patient for a lot of that time, everything that we've talked about here.
Right.
And then the patient goes home and we follow up with them virtually or by phone monthly, especially for the first 3 to 6 months. That's really that critical period where, of course, objectively, from my research, we want to assess how they're doing. We send out those assessments again, but we also want to make sure they have the resources needed. Right. I think that, like we established, is really critical. That is half of the equation, and they have to have those resources. So if they need a mental health provider, if they want to do EMDR, if they want to do TMS, if they, are interested in going to the middle of Montana and doing equine therapy, I have connections all around the country that we can provide that, or at least point them in the right direction if we can. Yeah. And then from there, hopefully, I only see them once. About 80% of my clientele are only needing this treatment a single time. We do talk about complex trauma, and of course, there's a lot of layers to those onions. Sometimes that has to be unwound in a couple treatments. There's no harm in repeat treatments. And sometimes through no fault of our own, even in the best circumstance, we have new stressors that reactivate our nervous system, or we simply just can't maintain those stressors on our own. So I do have patients that come back, maybe after 6 months or a year or 2 years, they're getting this treatment again. We see that a lot in like active military first responders that are going back out to
they're
trauma.
going back out and getting re-traumatized.
But hopefully for the majority of patients, this is something that can open that door so that they can really explore the benefits of all the traditional mental health treatments that are available.
Yeah. Well, this is awesome. I'm so glad I got to learn about this. I told you guys we're going to learn something. I learned all kinds of stuff. So I bet other people learn stuff.
Yeah. No, I'm so glad. And that's I really enjoy talking about it. And I mean, I could get on for another hour and talk about a whole another set of neurobiology issues and struggles and more about trauma. But yeah, for an hour, I hope I answered.
Oh yeah, you did. This is great. Am I allowed to ask how much it costs?
Of course, we're very transparent with that. Yes, please. Are you allowed to ask? No one can ask.
You want to say? Yeah.
Yeah.
I want to know.
So, yep. So it's $2,500, and that covers everything I said, including both sides, the intake, the consult, the follow-up, etc. That said, for all military first responders and their spouses, whether you call it secondary trauma or you call it circumstantial trauma or you call it something else, their spouses are definitely affected. We offer a 20% discount from that. So 20% discount for all our services for military first responders and their spouses. And that said, we take FSA, HSA, we offer advanced care credit, but beyond that, we also, as I mentioned, work with a number of nonprofits around the country. And based on your financial need, based on your circumstance, based on your, are you in the military, your job, are you a first responder? A lot of nonprofits that I work with are able to fund this treatment, fully fund the treatment for a number of individuals that are in need. We want to make this as accessible as possible.
Yeah, that's awesome.
And of course, when you put it into the grand scope of mental health treatment, if this is something you're able to do once or twice at most in your life, and then shorten that window of frustrated mental health treatment,
Yeah.
right? And
Yeah.
now you're actually making progress, you end up making up that cost very quickly.
You also make up the cost of not having as many medical issues and medical
Oh
appointments.
gosh, yes. Yeah,
Like,
how many times?
huge.
I mean
Yes.
I mean,
For high blood
even
pressure,
good
for
insurance has a
insomnia, for
deductible of several $1,000s, right? And if you have to go to the
yes,
ER because you're having a panic attack,
right.
you know,
Or you're
every
sick
month,
all the time and you can't go to work
or
or like,
yeah, you're losing money on, yes. So I mean, we could, that's a whole nother hour
it's a whole other
discussion
thing,
of
but I
how to
guarantee
save
it
money in
pays for
healthcare by
itself.
doing preventative medicine. And this
Yeah.
is definitely in the category of preventative medicine. But yeah, that is small in comparison. But again, we do want to make this accessible, and we have a number of ways that we can help individuals that are in need. And you know, occasionally I just do this for free because I see folks out there that are really struggling. So
Yeah, there's many people that I'm gonna connect you with after this, and nonprofits and other folks, and
yeah,
it's
I
great.
would love
Yeah,
that
I'm gonna
sincerely.
I'm gonna elevate what you're doing because I believe in it, and I'm not even there and didn't even get it yet.
Yeah,
But it sound it's like one of those things that like it sounds like a slam dunk. It's like where has this been, man? You've right like this
I know.
we've needed this, and so now that it's here, like it's awesome. This is
Yeah.
awesome. This is gonna
It,
change
it
people's
really is.
lives.
And thankfully there are a handful of other centers around the world that are doing this. There's about a half dozen in the
Okay.
United States. We again pride ourselves in how we do this. And again, I think most important is really the educational part of it, and providing the right resources
Mhm.
afterwards. If someone's doing this and is just saying, hey, here's your shot and good luck to you, you might have benefit, like we talked about,
Right.
but it's really not the same.
That's right. That's right. Yeah, and that falls into it's the same if you take psychiatric medicine, guys.
Yes.
It's
Yeah.
going to
Like
give
we were
you
talking
some
about.
benefit, but you're not going to optimize or capitalize on the benefit if you don't follow up with like some therapy and some other skills and
Correct.
things. And so
Correct.
this is that, right? I really like that you said it's not a panacea, right? Medication's not, none of
Yeah.
this is. There is an element of like you have to do some work in here or do
Right.
some work after the fact to sort of keep things going. But this will certainly give you like a massive head start. Yeah.
A massive head start. That's
Yeah.
it.
Well, that is this was great.
Thank you, Sarah.
I'm so glad that I know about this now. This is the thing. And honestly, you're not that far in Virginia. I drove to Cleveland when I went. It's not that
Oh,
far.
I had my patient I treated this morning before I got on the podcast is from Virginia. So
There you go. Yeah,
yeah.
exactly. Yeah, it's totally doable. Totally
Yeah.
doable. Well, thank you so much for this
You're welcome.
new take on old issues, and wow, what a fresh new take this is. How exciting. I
Yeah.
appreciate your time today, Dr. Michael,
Of
and all that
course.
you have shared with us. I hope you all learned something. I will see you again next week with another special guest with a new take on an old issue. I'm not going to give away too much. You'll have to